I'd like to thank the meeting organizers and the chairs, and I appreciate that this session is being held in English, and you should appreciate my doing my talk in English because my talk in Spanish would be harmful to your ears, and I do not want to cause that. I'd like to follow up on what my previous speakers discussed. When we look at patients with atrial fibrillation, we have simple goals to reduce symptoms, and I think we're effective in doing that. We would like to reduce stroke risk, and at least we have observational data that indicates that the stroke risk may be returned to the normal natural history of similar patients without atrial fibrillation. We'd like to reduce this alarming problem that we're becoming more aware of dementia and late cognitive impairment. We see from trials, this is the meta-analysis recently published by Dr. Ruskin and colleagues showing the association of this finding with AFib. And we hope that by restoring patients to normal sinus rhythm, that we will reduce this risk as well. Ideally, we would like to improve survival, but that is clearly an unknown, and the prospective trials that Dr. Herrera mentioned hopefully will give us some insight into that. So we all make the decision, balancing risk versus benefit. We know that there are procedural related risks. We think that there are long-term benefits, but defining the exact balance in an individual patient remains a challenge. We heard about the transcranial Doppler data indicating that there are materials associated with catheter ablation that are being transmitted through the carotid arteries. And we've heard about the finding of diffusion-weighted MR and flare MR images post-ablation indicating that there may be cerebral injury. And we have heard about those studies. So the assumptions that we make here are that the cerebral lesions that we observed post-ablation are not artifact. They look like they are real. They're a result, we believe, of procedure-related microembolism, and asymptomatic cerebral diffusion-weighted image lesions could be markers for risk for clinical stroke or possibly late cognitive decline. So the question is, where are these microemboli coming from? What are the risks that put patients in harm's way? And the obvious potential sources are thrombus, air, and char or coagulum. Here's an example. This is an intracardiac echo image in the right atrium in a patient without anticoagulation. And one can see in the right atrial chamber all sorts of little floating debris that is created from thrombus formation and embolization on the catheter. It's quite striking, and these essentially go away or are markedly reduced once a patient receives intravenous heparin. And we have data that indicates that the rate of asymptomatic cerebral embolism is associated with how aggressive the ablation is, but also the tendency for spontaneous contrast echo. We also see that the more aggressive the anticoagulation, the less likelihood of ACE lesions. And this trial published last year shows that the cohorts based on the activated clotting time during the procedure, those patients with a lower ACT had the prevalence of ACE lesions in the post-procedure imaging. So it's clear that thrombus at least plays some role in the formation of these lesions, and appropriate attention and aggressive anticoagulation intra-procedure is critical. And people who have large atria and have evidence of spontaneous echo contrast probably benefit from more aggressive anticoagulation. And in our laboratory, we target ACT levels greater than 350 in those patients. Now, what about char and coagulum? Well, we've seen this ever since the early days of RF, and we know that the formation of boiling char and coagulum at the electrode tip is related to excess heating at that tip, and we know that the critical temperature at that tip is 100 degrees when the blood begins to boil. Now, that can occur at lower recorded temperatures because the peak temperature at the electrode tip is rarely reflected by the temperature that the system is reporting. That is, there is temperature variation around the tip, and it may measure 42 degrees at the very tip, but back at another contact point may be exceeding 100 degrees. And we know that electrode surface area relates to the degree of concentration of heating. So at a fixed power, as you get a smaller electrode surface area, you actually have increased power density. And heating, remember, is the square of power density. So you get much more concentrated heating with a tiny electrode. And you can see in this cartoon here, with a large electrode, you can deliver a large amount of power without having without having excessive power density and excessive heating. But if you have a small electrode, you have much more current density. You have much more power density and the much greater potential for excess heating. And when you look at a catheter like the mesh catheter that has very tiny electrodes, one would think that that risk would be much, much higher. So the PVAC, the mesh, are special considerations that cause us concern about excess heating, coagulum formation, and then potentially jar embolism. And you can see this is a recording taken from a multi-thermistor catheter, a conventional 4 millimeter tip catheter with 5 thermistors at the tip. And you can see that despite the relatively low temperatures recorded on one tip, we have one thermistor that is showing temperatures exceeding 100 degrees. And this thermistor is showing spiking temperature. What we know when we see these spikes is this is formation of coagulum, and then that coagulum breaks off and embolizes and more forms. And then finally, at this point in the ablation, there's enough coagulum that the entire surface area of the electrode begins to be covered, and then we get the rapid impedance rise. So this situation probably occurs frequently during clinical ablation, and since we are only recording from one thermocouple or thermistor, we are unaware of this event occurring. Well, to understand a little bit more about what was going on in terms of exactly what material was being embolized during ablation, we developed an animal model, a pig model, using an extracorporeal circulation loop. And you can see here that we have a femoral artery cannula here going through this loop and coming back to a femoral venous cannula. And in this loop, we had bubble detectors, ultrasonic bubble detectors, as well as an inline 80-micron filter to catch any particulate debris that might be generated. And we did transeptal catheterization and did pulmonary vein ablation with various tools. And this is a type of recording that we saw with the bubble detector. And these top graphs represent histograms of the bubble number and size that were collected or detected by the device. And then the bottom graphs represent the time series of bubble production during the course of ablation. And you can see when power comes on, we have production of significant microbubbles, and when power comes off, that's terminated. Now, what we found also is that when we would inspect the filters, we would see occasional flecks, and these are small pieces. This one was 250 by 500 microns of embolic char. We also saw white fibrinous deposits that may be clinically relevant, but probably were more of an artifact of our test system. But these char emboli were real, and this is an example of a kidney. You can see blanching at the kidney surface, and you can see on the section a piece of char that's lodged in the renal artery, resulting in a small infarcted segment in the kidney. So these systemic emboli did have potential clinical consequence. And what we noticed in particular with the PVAC was that when it was being delivered in the bipolar mode with the 10 electrode PVAC design, there was potential for overlap between electrodes 1 and 10. This essentially led to a short circuit and very high current density at that point that was not present when the catheter was widely deployed. And this was easy to do if it was constrained by a pulmonary vein, causing the radius of the circle to be smaller. And here's an example of the bubble formation in one of these cases experimentally. And when we turned off pair number 1, that's electrodes 1 and 2, so we eliminated the 110 overlap, the bubble production went away completely. And then when we delivered power in the same configuration to just electrodes 1 and 10, we saw this high bubble formation. So it would seem that the 110 overlap was a big source of the problem. And in fact, if you looked at the cases where there was 110 overlap compared to those without, that accounted for most of the particulate material that was generated in these cases. And this was borne out in a recent clinical presentation where a high prevalence of acute asymptomatic cerebral lesions were found in clinical setting where there was a 110 electrode overlap. So in response to this, the PVAC is redesigned. It's only going to have 9 electrodes that will completely eliminate the possibility of a bipolar short circuit between those two end electrodes. 1 and 9 will be essentially monopolar, and that will prevent that problem. Now, one of the things with a small electrode that it's dependent upon to get any meaningful depth of heating is convective cooling. With a very tiny electrode, temperature controlled, you get very narrow depth of volume heating and correspondingly non-transmural lesions. So these technologies depend upon passive convective cooling to allow for more power delivery, more volume heating, and deeper lesioning. And that's something that is inherent with both the PVAC and the mesh design. One of the approaches that the PVAC designers are using is going to a metal that has higher thermal conductivity, thereby helping to dissipate hot spots, helping the thermistor to more accurately record what's the true peak temperature at that electrode tissue contact point. And comparing gold versus platinum, you see that we're able to give higher powers, and as a result, lesions were trending toward deeper lesions. But more importantly, the temperature range recorded was much narrower, less variance in the temperatures. And so we think that this is probably not only more effective, but probably a little bit safer as well. The mesh catheter, when I looked at this design, I thought that this was a setup for hot spots and particulate embolic complications associated with its use. And I was concerned about that. We did a series of experiments with a similar type of extracorporeal loop setup and bubble detection. And in fact, the mesh performed extremely well with very minimal excess heating. And here's one example of a type 2 microbubble burst, but that was an extremely rare event with this design. We did see a little bit of fibrinous material. Interestingly, we saw this as soon as we crossed the septum with our catheter, and saw some as well with irrigated RF ablation. This may be an artifact of the test system, or these things may be real. We're not quite sure. So the summary of the mesh data was that microbubble and embolic protection from the mesh was similar to irrigated RF ablation. We did see emboli with transseptal crossing alone. We saw histology that showed minute accumulations of platelet-rich material on the filter, but these events were infrequent to rare in terms of coagulated material collected on the filter. And I think part of the explanation is that even though these are very tiny electrodes, instead of being delivery from individual tiny electrodes, the electricity really acts more as a field effect. So these multiple tiny electrodes deliver current in a large area and virtually act as one big electrode and prevent any areas of very high power density and overheating. Now, finally, we know from transcranial Doppler, we know from this experimental model that we can generate material, embolic material, gaseous and particulate, but does that really account for what we see on the cerebral lesions? Part of the problem with animal testing is that most ruminates, pigs and goats and most dog species have a structure called the rete mirabile, which is this plexus of arteries that are in series with the carotid circulation. And embolic debris going up to the head doesn't make it to the brain. And we actually did a bunch of MRI scanning on the pigs, and all the brains showed no lesions. You saw that the kidneys had lesions. It's in part because the pig brains were tiny compared to the rest of the pig, but also because of the rete mirabile. So we wanted to determine, are these small particles really, can they produce the type of finding that we find in patients who are undergoing AF ablation? And so we used an animal model, beagles, which do not have the rete mirabile, and we did direct cannulation of the carotid with a 4 French injection catheter. And we did two things. We injected small particles, and these particles were denatured blood that were ground up and sifted through a screen to result in particles similar to the size of particles that we recovered on the filter in the other experiment. And then we also mixed up air with contrast and saline to create bubbles. And here's an example of a bubble injection through our system showing that, that we had a similar type appearance of these microembolic bubbles. Now, importantly, the volume of bubbles were about 2 or more magnitudes greater than the number of bubbles that we saw during actual ablation. But we wanted to have a proof of concept to say, does air microbubble cause lesions? And what we found was, in fact, we did get lesions. Here are gross findings in the brains of these animals. You can see in the particulate embolization, these leptomeningeal vessels showing accumulation of some of this debris. And associated with both air and particles, you can see small lesions, microlesions in the brain on gross examination that correlated with lesions on diffusion-weighted MR imaging. So real pathological lesions associated with these MR lesions. And the findings of these lesions, we could see that there was endothelial proliferation, there was glial cell activation, and there was perivascular lymphocytic infiltration. And these are findings consistent with ischemic injury. And we found these findings even in areas where the diffusion-weighted image dissipated by day 4. So the acute diffusion-weighted image, in the absence of a flare image, were associated with real ischemic injury to the brain, not infarction per se. There were scattered neuronal necrosis, but injury. And then the cases with positive flare images were associated with the larger lesions that we saw on diffusion-weighted imaging, and these were more extreme in terms of their histopathological findings. And then we had some cases where we had clear focal stroke with accumulation of particulate matter in larger penetrating arteries, and a clear finding of a focal stroke that had corresponding necrosis on pathology. Now, if you looked at all of these animals, and these are the data from those that underwent gaseous microembolization, you could see that the animals with no diffusion-weighted imaging abnormalities had no pathological lesions, whereas those that either died early or had DWI lesions all had histopathological evidence of cerebral injury. These are data from the particulate infusion, and we had similar findings. And we did have a couple of animals that had a number of particles injected into the brain, had no DWI lesions, had no pathological lesions. And that's either because they were large enough that they clogged up in larger arteries and the collateral flow managed to perfuse the brain. That's the likely mechanism. Whereas those animals that showed MR lesions all had pathological lesions. And these are data from a clinical study that I mentioned earlier, and showing the acute findings on diffusion-weighted imaging and the corresponding findings on flare in only a third of those patients, and in only one of those patients that notably had the largest lesion, a 14-millimeter lesion, positive on both DWI and flare. That was the only patient that had evidence of persisting abnormalities on follow-up scanning. So it may be a size and sensitivity issue as well. You know, with conventional MR imaging with a 1.5 Tesla machine, typical slice thickness is 3 millimeters, sometimes 4 millimeters. So you do not get that same spatial resolution that we're used to with CT scanning, for example. So you can miss smaller lesions, and it's not that they're not there, it's just that our sensitivity of our technique is limited. So in conclusion, AF ablation with both approved and investigational technologies can produce significant gaseous and particulate microemboli. Experimental embolization with gaseous and particulate microemboli can produce transient diffusion-weighted images and more persistent flare and T2 MRI lesions. The pathology of these lesions show varying degrees of ischemic injury, and asymptomatic cerebral DWI lesions may be markers for clinical stroke. So AF ablation may produce microinfarcts that could lead to cognitive decline, but the clinical question that all of us need to address is the opposing effects of lifelong AFib and cognitive decline must be considered. Thank you.